Now we will be starting this new session. It's a lot of new information. This is the 8th year of this event, and I want to thank all of the organizers for giving us this space because bioethics is always important to speak of. The pandemic of COVID made it even more relevant. We not only have complex technical issues that we have to face, but also we face different new situations that are even more ethical to speak about bioethics. So the globe was speaking about health issues and intensive care issues were more relevant. So people began to speak about the ICU, about intensivists, about critical care units, and people were more aware of our profession. And there are a lot of dramatic and difficult situations like selecting which patient will be intubated to go into the ICU. And this generated a lot of knowledge that we have to review and analyze if we have learned of the pandemic about some. What I will try to summarize here is how can we navigate morally and ethical a lot of things that we face, not only during a pandemic, but in our day to day. This image is maybe known by some of you. This is a historical event. And in the beginning, the critical care patients were taken. This is Malta. This is like a fortress. And the patients were taken there to the critical care patients. Through time, technology evolved, but disease is always there, and we face to have different solutions. This is the timeline of medicine and medical technology. This is the polio epidemic in Copenhagen in 1952. And these epidemics made us develop new technologies and force us to move forward. Here we see death, the pest, and we see a fork on the right hand wearing a gown. And here we see on the right the personal protection elements that we had to use during the pandemic. So the doctor during the pest, during the epidemic times of centuries ago, looks similar, wearing also a gown. We have to continue working in bioethics, and the common denominator in pandemics or severe accidents, one of the underlying features is fear. Fear because we don't know what we're facing, what are the solutions, how we prevent ourselves from getting infected. So there is a current medical paradigms on the left. This excludes psychological, social issues, and cultural problems. And in intensive care, we face conflicts. Suddenly, people were aware of the ICUs, of the intensive care, and in 1974, they began to speak about respiratory failure, circulatory failure, and we believe that in the future, we might have new pandemics. And the lungs have been one of the main organs affected by several pandemics. So, this is a summary of Spain, of the intensive care medicine services. And in the first moment, we really did not know how many beds there were available in Spain and if we would have enough to give the best care. Here we see the total number of beds for adult critically ill patients were 4,738 beds in Spain. These are news of Spain. Not even the health ministry knew the exact number of ICU beds. When these numbers are updated, we went from 4,100 to 6,000 ICU beds. We know that many have been adapted, and we know that this can grow in the future. This is a comparison between Spain and Kazakhstan. They are very different countries. In these stats of 2014 and then up to 2017, in Spain, there were 238 beds per 100,000 people. In Kazakhstan, according to the volume of the population, they said that they had 418 beds for 100,000 inhabitants. So Spain had problems, and worldwide, many other countries suffer from the lack of beds of ICU. We really have to know how many beds we have available, eh, and we have to have adequate triage. But we need figures. We also need to know about the increase in human population. The language was about battle, and this increases the fear of the unknown. And it causes two mistakes: a diagnostic failure. We should speak about a crisis and not a war. And also, the perception of war causes wrong models of human behavior and decision making. So, we should use better language. And during the pandemic, there were many problems, and there were ethical issues about human rights, the freedom, civil rights, the loss of privacy, and an important one was moral distress and the burnout of the healthcare professionals and infoxication. The overload of information, this made the process even more difficult. And the healthcare professionals we received a lot of studies and false information. And the New York Times had this editorial: the pandemic claims no victims, the prestigious medical journals, because we could not do proper studies and conclusions in the medical treatments. And the health staff suffered greatly. They were quantified like in waves. When the cases increased, there was fear, uncertainty, the protocols changed, and we had three waves. The third wave was not so much a moral issue, but it was a physical and psychological burnout of the medical staff. And in the fourth wave, we can really speak about the burnout. So the medical staff had insomnia, And many of them required healthcare, medical assistance for psychological issues. So we have bioethical deliberation. We have facts, what is happening, what can we do? And one of the things that we learned is that they should let us do what we know how to do best. And the tracheal intubation, the early prone decubitus, and avoiding the use of compassionate treatments without proven scientific evidence. And that what was what it we had been doing before, but we had overwhelming amount of evidence. So the COVID was a white swan or a black swan. What have we learned? This is a WHO publication, and we have to be able to anticipate a new pandemic. We shouldn't be able to call a pandemic a black swan. We should be prepared. And WHO says that we have to prepare for the next pandemic, prioritize the pathogens that will be responsible. And they even speak about a term that says pathogen X. It's an unknown element that will come in the future. It could be a benign germ, but could uh, change and have pathogenic effect. There are four groups of pathogens, the operational definitions used, and they are classified. These are the black swan versus the white swan. The possibility of becoming a pandemic, they classified the risk of low, medium, low, and high. I highlight here one of the examples, the Arenaviridae family, very well known. And here we have other viruses that we see on the slide with a high risk of becoming a pandemic respiratory event. Here we see it's easy to understand that many viruses are RNA on the right. And we have to continue designing vaccines to approach these kind of pathologies. High risk is RNA viruses, even larger than bacteria. Bacteria are in smaller amounts. What are the key messages? One that I find very important is to insist that we can save lives if we are able to have measures on time. We have to prevent and begin thinking how to improve the strategies. We have learned from COVID, so we should be more prepared for the future. We have to continue speaking about bioethics. The protection of the health staff is a priority and should be a priority in the future, and avoid reducing the resources. I want to point out the moral stress, and the ethical committees should be active in all of the hospitals and be prepared to face this kind of pandemics. In Spain, we were the first ones to suggest that Doctors and the staff should have priority if they need an ICU in the future. How to select the patients in a situation of collapse unit? We should have a clear flowchart and plan. That discussion in the ethics committee is mandatory. Now, to finish my presentation, what is the practical projection of bioethical deliberation during pandemics? The main conclusions drawn for COVID are listed here. We have to have more flexible accompaniment, the creation of interdisciplinary committees independent of the healthcare professional. Insist that COVID-19 is not the only existing pathology, and intermediate courses of action must be sought. It is prudent to frequently reassess the situation, and all of the healthcare staff should have education in bioethics and be prepared for the future, understand the scope of our professional duties, and have common values about the public policies. We should all work together to understand the scope of our professional obligation with society. This is my last slide. In any case, and independent of any situation, the triage must be supported with protocols and recommendations. If we don't have certainty about the pathogen, then we have to use a common path and avoid treatments that have not been proven and might be damaging for the patient. Age should not be the only criteria. The triage decision must be taken by at least two doctors. And do not differentiate between COVID-19 patients and other diseases. The term social utility in reference to elderly or disabled people is ethically discutable. And it is not acceptable the prioritization only because of the order of arrival. And communication is key, not only among us, but to the families and the patients. And the ethics committee should be available 24/7 to give support to complex decision. So with this, I finish my presentation. Now we welcome Jose Manuel Gomez Garcia, also an intensivist. He is going to continue speaking about the lessons learned during COVID. Good afternoon, everybody. Thank you so much. I will proceed to share my slides. Can you see my slides? Can you hear me okay? Good afternoon, everybody. Greetings from Madrid. Thank you so much to the organizers, Dr. Julio Villanueva, Pablo Cardenal, and the whole team of technical support that allows us to flow seamlessly, and to the sponsors, of course. I will try to speak briefly about the moral values that we have strengthened. I believe we have learned in bioethics. And pandemic taught us many important things. First, solidarity. It's a value that has been reinforced. And this solidarity is among neighborhoods, among your family, and also among professions. Second, the importance of the family and accompaniment as a social, emotional, and economic pillar. We have strengthened the family bonds and also for emotional support. We have also learned to value what really matters. Sometimes we forget to enjoy certain things. We are too much embedded in our jobs and having a good economic status. So this pandemic made us think about maybe we could live with less and enjoy other things like being together, having freedom, and enjoying simple things of life. It also helped us to pause, to have inner reflection, and sometimes we got bored at home, and the children also learned from the pandemic. This pause helped us to think about other things. And being bored is not that bad. It's good. It's good because it stimulates creativity. Also, the environment was benefited. There was less pollution, and this had a positive impact in the planet. We also now see empowering of science, and science is really valued now to work as a team to face difficult and complex situations, pandemics, and catastrophes. Catastrophes like, for example, in Valencia, Spain, they're facing difficult moments now, and the work as a team is key. And we have seen that health is important, something that we really have to cherish. And also, the different health professions have been highlighted during difficult times during the pandemic. This is also a list of bioethics decisions, like, for example, the triage decision is obvious. Unfortunately, there is not equity in health access around the world, and there are different socioeconomic levels, and sometimes there is an unbalance. There is unbalance. The availability of resources, who decides about the resources, what moral values can we base on to decide which patients should be prioritized and others not. I would like to highlight that during the pandemic, the decisions of triage were very difficult. There was scarcity of resources, And we didn't rationalize the resources. And unfortunately, we didn't have enough. And we had to determine which patients should be taken to ICU and which ones to reject. If we don't have enough resources, well, we have to increase and improve the access to resources. Many ventilators were built in a very short time and set up in different ways. And staying at home and taking PPEs, then it was a way to try to prevent the dissemination of disease and have more resources. The ethics of using what is right. And in the ICU, we had to prioritize, but we know which are the inclusion criteria according to the patient's possibilities of surviving and the other comorbidities. Some patients can wait and others cannot. So there were some patients that had very little surviving. So we had to reject those patients if they don't have a possibility of surviving. And we have to balance the resources, benefit and cost, and cost and opportunity, and cost effectiveness. We have to analyze many things. These are efficiency criteria so we can have maximum benefits. And this, the utilitarist ethics, teleologic. In normal situations, when these resources are available, we practice deontologic criteria of equity, the right to health, non discrimination, and dignity. But when we have scarce resources, these are not enough. And we need to use utilitarist ethics. We try to give resources to those that have the highest possibility of surviving. So, this is kind of an ethical dilemma because everybody has the same right to health, to be protected and not be discriminated. But we have to make decisions and we need criteria to support our decisions, trying not to make mistakes. And we have to make drastic and tragic decisions. And we decide who goes to a respirator and who doesn't. A dilemma is something morally very difficult to solve. It's tragic and it's unavoidable. A dilemma can not be solved ethically. That's why it's so difficult, complicated, and tragic. So, a dilemma is being forced to make an impossible decision. Here we're standing, deciding between what's good, what's bad, and you don't need ethical basis to understand what is bad and what's good. But there are other things that depend. It depends. So we have to choose between two things that can be wrong in two bad decisions. So, which is the least worst decision? And the utilitarist ethics presented by these authors, Jeremy Bentham and John Stuart Mill, speak about utilitarist ethics and the greatest happiness principle. And a few have to be sacrificed for the benefit of many. And we have to save the largest number of lives possible. And we have to make choices. And that's utilitarist ethics. I know I don't have a lot of time. And if we speak about utilitarists, we have to speak about the virtue ethics. And we have to be prudent, commitment, honesty, strength. In any case, we need planning, transparency, and triage. Another lesson learned is the need to prevent ethical planning for an influenza pandemic. And we have to be ready for the next one and be prepared because we have learned many things and we have to be prepared for the next pandemic. All these articles speak about the need of having enough resources, have plans ready and pre-designed for the emotional and psychological support of the medical staff. Another important point is the accompaniment in the process of dying. This process taught us a lot. And the most transcendental point, there was fear and to die alone is not human. This has made us think about the vulnerability. We are fragile human beings, we are interdependent, and we need others and our loving ones. So we have a moral wound. Human beings need a story to learn from. And the last stage of life is death. And we need to be accompaniment in this process of dying. We should have dedicated more effort to support this process. So, in the different sanitary institutions, many tried to face this issue of loneliness and dying alone. Another ethical issue is about personal freedom and the common well being and public health. John Stuart Mill, the father of neoliberalism, speaks about freedom and our own borders. My behavior might affect others. So we have to be responsible, and we have to be autonomous, have respect and solidarity for others. In the Spanish society, we have spoken about the principle of autonomy and collective benefits. They just said that we had to stay home, use masks, and it was mandatory, period. Your freedom was taken away, but it was for the well being of others. So, speaking about public health, it's important to consider without forgetting others' freedom. Cicerone said the health of the people is above the law. John Locke also spoke
Cicerone
about
said the
this.
health of the people.
Individual freedom versus the common good. There are many other patients that are forgotten during the pandemic. For example, cancer patients, many died because they couldn't receive treatments on time. And many other patients died and got sicker during the pandemic due to lack of care. So, can a virus undermine human rights? There are many ethical issues discussed by the governments about the people's freedom and the well being of the society. We have to change fear for responsibility. We have to be ethically responsible, and we have to highlight the importance of the health of the health staff. And we know that the health professionals have been affected psychologically, emotionally, and physically. We see a lot of situations that we have seen in different media, and they had lack of PPEs and they were afraid. They overworked many nights, not sleeping at home. They slept at hotels. Images like these coffins, doctors that have died of COVID, protests, and this reflects the psychological pressure of the medical staff. So, not everything was okay. We didn't do maybe our best. We were not prepared. The medical staff has been affected morally because of having to do triage and overworking and not sleeping at home. And there was fatigue for compassion. They had to see many patients died lonely, and the medical staff had to be a substitute of the family and of the loving ones of many patients, and this led to a burnout. Also, I would like to speak about the rituals and the importance of the rituals. We have to shake hands, mourning. There are many rituals in society and in different cultures that we have to respect. Unfortunately, many disappeared during the pandemic. And the rituals are important. for society. They create community, a sense of belonging, of connection and support. They give us a chance to pause, to enjoy, to relax. And they also create a narrative, and they also allow us to express our feelings. Unfortunately, during the pandemic, there were no rituals. And we know that other rituals, for example, like applauding the medical staff at a certain hours, gathered us as a community. I would like to finish with the word hope. Hope for the future. It has to do with love, with faith, and these are fundamental to overcome tragic situations like the pandemic. Also, being prudent, being strong are not enough to face this kind of catastrophes. Faith, transcendent love, and hope make us have a life full of meaning. So, hope is being centered in not yet or despite of. Hope speaks about the future, about a life worth living today because of a hope of a better future. And having hope is good to fight fear. And it helps us to overcome negative feelings. And we can see a light at the end of the tunnel. And that hope is what we can hold on to in difficult situations. So it is us, not only me. And being having hope is being optimistic, but it's not the same. It's not the same. The optimist is passive, and it has uh, that belief that we are going to have a better future and that the power is within you. And it makes us be closer to others, be more empathic. This is not hope. Everything's going to be okay. We have a bright rainbow. No, that is not hope. Hope is beyond. So, thinking about us, I have hope in you. It's because I think of a better us that I have hope. So, take
Hope
care for the
of
future.
each other.
Thank you so much. So, if you have any doubts, I will be available.